This disease and related dementias not only affect the patient in limiting their daily routine activities, but also place a significant burden on the families. Some of the key questions our staff face from caregivers are: what stage is the disease at? What to expect next? Families and caregivers sometimes struggle to draw the line between how much of the changes are from the disease itself versus the person they knew all their lives, and how to be true to these different facets of the same person. This translates into how to reset expectations regarding household duties, into questions of safety, how to manage their medications and finances and future planning. Tough questions, but these can be navigated together with your healthcare providers and the social worker team working to help you.
Okay. If you want to get started.
Okay. So good evening and welcome everyone. We're going to give a minute or two to let everyone log in before we get started. But welcome and happy Black History Month. I am Imani Capri and I will be your host and moderator tonight and for our second webinar as part of the 4th annual Black History Month webinar series. I am the creator and host of the international award-winning radio show Conversations in Courage with Imani Capri, which currently airs on Tuesdays at 11 a.m. on 95.9 FM WOBU Cleveland. This year's program is presented by the Cleveland Alzheimer's Disease Research Center, or CADRC. This federally funded grant was awarded to the Cleveland Clinic, University Hospitals, Case Western Reserve University, the Louis Stokes VA, and Metro Health Medical Center to work together as a research center without walls to study Alzheimer's disease and memory loss. I will be hosting 3 of the 4 weekly webinars each session, each of which will take place on Thursdays at 6 p.m. Each week, we will begin with a 5 to 10 minute celebratory presentation of African-American pioneers to highlight their accomplishments. After the presentations, we will then delve into the topic of the week with our esteemed panelists, followed by a Q&A session from you, our audience. We would like for this to be interactive, so if you have any questions, please make sure to write them in the chat. All of the webinars will be recorded and the links will be sent to you following each webinar. This week focuses on Caregiving 101, Preparing for the Future. Our panelists this week are Dr. Kalisha Bonds Johnson, Dr. Macy P. Smith, and attorney Corey Wisenot. But first, it is my pleasure to introduce Gordon Williams, who will present the celebratory presentation for tonight's webinar. Gordon Williams was raised in Cleveland, Ohio, and obtained his BA in psychology at Cleveland State University. He was first introduced to the field during his time in undergrad working with Dr. Kenneth Vail, focusing on existential psychology research from 2014 to 2016. From there, he was hired at University Hospitals in the Clinical Research Center as a clinical research coordinator in 2018, and finally settled in the Neurological Institute Clinical Trials Unit, focusing on stroke as well as brain health and memory, the department in which he currently resides. Tossing it to you, Gordon.
Awesome. Thanks so much, Imani. I really appreciate that. I'm going to go ahead and share my screen to show my presentation. So just give me one moment. Awesome. So once again, good evening, everyone, and welcome to our week 2 presentation. Today's presentation is on Mary Eliza Mahoney, the first African-American licensed nurse. Starting from the beginning, Mary Mahoney was born in the spring of 1845. Some sources have a birth date of April 16th. Other sources have a date of May 7th. Her parents were freed slaves from North Carolina that moved north to Massachusetts before the start of the Civil War. Mahoney was enrolled into the Phillips School located in the Beacon Hill neighborhood of Boston. In 1855, Massachusetts law required school desegregation, making Phillips School the first integrated schools in the state. Just for context, segregated schools in the United States were not marked unconstitutional until 1954. The New England Hospital for Women and Children, also located in Boston, was one of the first nursing schools beginning operations in the United States in 1862. The hospital provided health care not only to women the hospital only provided health care to women and children. Mary Mahoney worked at the hospital for 15 years in multiple roles, such as a janitor, a cook, a washer, and also had the opportunity to work as a nurse's aide. Her time as a nurse's aide is what allowed her to learn so much about the actual nursing profession. This picture here of the New England Hospital for Women and Children had opened in 1862. A fun fact is that the hospital did not include male patients until 1951, 89 years after its actual founding. At the age of 33, Mahoney, along with 41 other students, were admitted to a 16-month program for the New England Hospital School of Nursing. The program originally only allowed women aged 21 to 31. However, Mahoney was accepted partially due to the fact that she had worked at the hospital since she was 18 years old and worked up a good rapport with the hospital administration. By 1879, only 4 of the 42 total students that entered the program completed it, Mahoney being amongst those 4. Her completion of the program made her the first African American in the United States to earn a professional nursing license. After completion of the nursing program, Mahoney faced much discrimination as a public nurse and as a result shifted to private nursing, primarily for wealthy white families. After decades of working as a private nurse, in 1908, Mahoney co-founded the National Association of Colored Graduate Nurses. Later on, in 1911, Mahoney served as the director of the Howard Colored Orphan Asylum for Black children in Long Island, New York. She served as a director for 1 year. Mahoney is included in this picture. Unfortunately, I was not able to decipher which one just because it's a little bit old and faded, but this was actually a picture of their first conference. So I was glad I was able to get that. Finally, Mahoney retired from nursing after working 40 years. During her retirement, she was a supporter of women's rights, and in 1920, the 19th Amendment was passed. Mahoney was among some of the first women registered to vote in the city of Boston. Finally, Mary Mahoney passed January 4th, 1926, at the age of 80, currently buried in Everett, Massachusetts. Here are the sources that I utilized for today's presentation. And if you have any questions, comments, or concerns, that is my email. Thank you so much for your time, and I'll pass it back to you, Amani.
Thank you, Gordon. So now I'm going to introduce our awesome panelists. First up, we have attorney Corey Wisenot. She is a loving mother and wife, a mother of 2 incredible sons, and is a Cleveland, Ohio native. With over 10 years of experience in her area of practice, Corey is deeply passionate about helping people understand and navigate estate planning and probate law. Her mission is to educate individuals about the importance of memorializing their wishes, ensuring they have peace of mind for the future. Corey is particularly dedicated to empowering her clients to build generational wealth, regardless of their income level. Not only does she hold a law degree, but she also holds a degree in psychology, allowing her to approach estate planning with a deeper understanding of her clients' needs. Corey believes that effective estate planning goes beyond simply drafting legal documents. It's about understanding the why behind each decision. She strives to make sure her clients feel truly seen and heard throughout the process. With her compassionate and client-focused approach, Corey is committed to guiding individuals and families toward a secure and prosperous future. So welcome. Next up, we have Dr. Kalisha Bonds Johnson. Dr. Kalisha Bonds Johnson is an assistant professor on tenure track at Emory University's Nell Hodgson Woodruff School of Nursing in Atlanta, Georgia. She is also a psychiatric mental health nurse practitioner at Emory University's Integrated Memory Care Clinic, a primary care clinic tailored to the care of persons living with dementia and their families. Additionally, Dr. Bonds Johnson is the principal investigator of the Decide Research Lab, which focuses on creating culturally tailored decision-making programs to improve the quality of life of families of African American persons living with Alzheimer's disease and related dementias. She graduated from the University of Tennessee at Martin with a Bachelor of Science in Nursing in 2007, graduated with the Master of Science in Nursing from Vanderbilt University in 2012, and graduated with a PhD from Oregon Health and Science University in 2019. In 2021, she completed her postdoctoral training or training after completing her PhD at Emory University. Dr. Bond's research focuses on improving the quality of life of African American persons living with dementia and their family care partners, as well as improving the communication between these families and their primary care providers. So welcome, Dr. Bonds Johnson. And next, we have Dr. Macy P. Smith. Dr. Macy P. Smith is internationally known for her work on dementia compassionate care practices and family caregiving matters. Her real-world, unapologetic approach to practical caregiving has been published in national and international professional journals. She is a licensed gerontology social worker and an award-winning Alzheimer's and dementia educator with over 24 years of experience coordinating care for aging and vulnerable populations within her private geriatric care management practice, Diversified Training Consultants Group. Dr. Smith is an advisory board member with Lisa's Care Connection, founded by Emmy award-winning TV and radio personality and philanthropist, Lisa Gibbons. She is also the vice chair of the Board of Trustees at South Carolina State University, making her the first woman, regardless of race, to serve in this role for 2 terms in the history of the university. In addition, Dr. Smith is a best-selling author. Her most recent self-published guide, A Dementia Caregiver Call to Action, The Journey, has been featured as a #1 new release on the Amazon bestsellers list. So welcome, 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 ladies. I'm excited to be here with you this evening and very much looking forward to getting into our discussion. To start off with our first question, and anybody can jump in on this, what is a care plan and when should you begin creating this plan?
Care plan in what way? As in medical or legal or both?
How about both? Because sometimes I think a good care plan would probably include aspects of both, right? The medical aspect and the legal aspect.
Well, I can speak to the legal at least. I'm definitely nowhere near a medical doctor. That actually should be, I say, starting at the age of 18. You know, that as soon as you become an adult, you know, at least considered an adult in this country, I think you need a plan. You know, that tomorrow is promised to none of us. I don't care. I pray to God we all make it to, you know, to being in our golden years. But regardless, I think you need to be able to dictate what you want done with you, as in how you want to be taken care of, you know, who you want to do it. And so I think that those are very important pieces to a care plan. And though obviously it's going to evolve as you do, you know, that it should start when you have the legal ability to do so.
And I'll add to that. That was a good question you asked, Attorney Wisenant, because when people hear the term care plan, they do think clinical, but it doesn't have to be clinical. If you are concerned about your life, if you're concerned about your health, if you're concerned about longevity in America, to your point, you need a care plan. It is about care. Everybody wants to go to heaven, but don't nobody want to die. Everybody has an appointment, right? And so you want to be able to outline, I don't care if it's on a notebook, I don't care if it is on your phone. There are 4 key elements that are in a care plan. What needs to be done, why it needs to be done, who needs to do it, and when it should be done by. It should be fluid. It should be updated and changed at any given point in time. You could be in a relationship today, not in the relationship tomorrow. That oldest child could get to acting up and they don't need to be making decisions on your behalf. And so you want to be open to have a fluid plan in place. I think it comes to a conversation. I think we'll get into this later on in terms of what those plans look like. Advanced care planning document, do not resuscitate order, end of life documents, what that looks like. Nobody wants to talk about it, but we have to talk about it, especially in the Black community. There's so many taboos. You know, I'm from South Carolina and we believe in the power of the tongue. So like your tongue is, you speak life and death. So don't nobody want to talk about dying. People don't want to talk about mental illness in our community because they think that that means it's going to jump on them some type of a way. And so a plan is simply what it is. It is a plan for your care and what you want it to look like.
Yes, and before we move on to our next question, for those of us who are taking notes in the audience, could you please repeat those 4 key elements that you said your care plan should prioritize?
Okay. What needs to be done, why it needs to be done, who needs to complete it, which would include more than one person because you want to be able to build a team within that plan, and when it needs to be done by. So you want to have a hard stop. You want to have a target date. However, it needs to be updated. You want to be open for it to be modified because life happens.
And may I please add in,
Sure.
though I know you said a notebook, please don't just write it in a notebook. Please come see somebody like me, because I'm gonna tell you something right now. There's a whole bunch of stuff that ends up, you know, stuffed into a corner. But if you have it legally memorialized, not only does your family have to follow it, but so do medical professionals. So do financial professionals. So yes, I want you to have it done. And I think that those 4 characteristics are phenomenal, but let's make it solid.
Solidified.
Thank you. We're going to move on to our next question. How do you determine who should serve as a caregiver in the family, especially when considering job and time restrictions, young children, finances, and life?
Yeah, that question is loaded a little bit, right? Because there's sort of this assumption that there's often a discussion around who is the person that ends up being the one that takes on this care partner or caregiver role. And we know, be it society, family dynamics, culture, all of these different things play a part in who ends up being the person that takes on the role. So if you're an only child and it's your parent, then more than likely it's you. You know, if it's a family full of individuals, you would think, okay, well, I'm going to work with my siblings and my aunts and this, but sometimes it does not happen that way. And so I think, as Dr. Smith and Attorney Wisenot pointed out, it really is so important to start planning and thinking about who is in that inner circle. Who can you trust? Who would you want to be a part of that? Recognizing that sometimes just because you want them to be a part of the process doesn't necessarily mean that they will.
Go ahead, Attorney.
Oh, I was just gonna say that I think that we use primogeniture big time when it comes to who's in what order, meaning like firstborn, secondborn, and all down through. I've really come to realize that you have to think about, especially when it comes to your children, their personalities. You know, that if your oldest is skittish and is, you know, would not want to make decisions like that, they're very emotional, that's fine. Nobody's saying that's wrong. But maybe you don't want to make them healthcare power of attorney for that reason. You know, would you scar them, you know, for doing that? And also, your married secondborn may be the one that's like, look, this is what's up. And maybe they would be more suited to doing so. So I was saying that in a psychological standpoint, I think you really need to talk about the personality of the person as well as, you know, their outside duties, to make sure that you're not asking them to do something that would be ridiculously uncomfortable for them.
Yeah, I'll say too, our families are a lot smaller than what they used to be. And so the likelihood of it being only one child in the family or no children in the family, that's a whole other conversation we probably can have later on as well. But if you're the only child, by default, you would become the caregiver. But we know we got play cousins, we got play aunties, play grandmamas, right? And so you may have to build a team from your logical family, your logical support around you, because you can't do it alone. And many people are caregivers and they don't identify as caregivers. And so when they don't identify as caregivers, then they're not receptive or open to the type of supports that are out there, because they're talking about somebody else. They're not talking about me. And I'll also say too, when you do have a big family, and as a care manager, I also do, I'm a court-appointed guardian. And so simply because there's a whole bunch of people in the family, a whole bunch of siblings, doesn't mean that you're going to have the best possible outcome in terms of planning. Because if somebody does not want to be the caregiver, do not force them or shame them into caregiving, because what that can do is it increases the risk of abuse, neglect, and exploitation of that vulnerable adult. And then that person will wind up in legal trouble. And I'm sure Attorney Wisenot can speak to that, because they didn't want to do it in the first place. In Black communities, we got an issue, number one, with minding other people's business and being in other people's houses and don't want nobody in their house, right? And it's a shame JoJo and them put their mama, in a home. You gonna come over here and take care of her? We gotta stop allowing people dictate to us how we take care of our loved ones. And even if there is a daughter or a son, they feel guilt when they have to look at out-of-home placement. And so when they come to me, we talk about their abilities, their ability both mentally, emotionally, physically, financially, whole other conversation to have, to take care of that person. And if they can't do it, we develop a plan, going back to what we were talking about earlier. And if this plan says it and it outlines it, then there's no neglect. And so we have to really stop allowing other people to dictate what we do within our homes and in our families.
This is so good. You hit on so many key points. This next question, though, I want to target to Dr. Bonds Johnson. We know that sometimes a patient or caregiver can be resistive to receiving aid. Dr. Bonds Johnson, how should we navigate if the primary caregiver, such as a spouse, is not receptive to the idea of care planning or receiving help from others?
We always have the saying with dementia: if you've seen one person live with dementia, you've seen one person living with dementia. And I think that is the same for families. There is no one size fits all approach. If you do X, then we're going to get Y and Z. Every family is different. For one family, it might be, that favorite grandchild. She can get grandmama to do anything. She can get granddaddy to do anything. If that's the case, use that grandchild to help. It might be that it's, only his son can get him to do that. Sometimes using and leaning into those relationships that work really well in the family can do that. Like, my aunt will tease me all the time. My grandmother raised me from the time I was 2, and she'll say, you can get my mama to do so many different things. Our relationship is different. And so knowing how to use those relationships when you can is helpful. Sometimes using healthcare providers is helpful. I tell my families all the time, somebody with dementia will be mad at their family for months. Me, they totally forget that they are mad at me. They will say with their piece, they'll be mad at me for a day, and then it's, Dr. Kalisha, I'm so glad I saw you today. And so using those of us who are a part of that medical care team to say, well, Dr. Kalisha said you needed to do this, or Dr. Smith said do this, sometimes leaning into other people so that they don't blame you. But there is no magic book, no magic pill, there's no magic plan. The one thing I do tell my families is, you try something one day, if it doesn't work, guess what? Usually you get to try something different tomorrow. Sometimes you get to try something different a couple hours later, depending on where they are in this disease process and how you're managing it. But just don't give up. Just know that if your heart is in the right place, you will find strategies that work. And we are here to support you as you do that.
Yes, I can.
And so thank you for.
Oh, sorry, forgive me. I was just gonna say, I completely agree. And having somebody on the outside is huge, because you're right. They recognize you. They think of you as, somebody that should not be telling them what to do. So having someone else of authority say what you've been saying just can get through. So I agree with you there.
I love both of those points. And of course, before we got started, we talked a little bit about needing to challenge certain habits that exist in our families, particularly in African American culture, where sometimes our elders and or families don't want to be proactive about discussing some of these estate planning or care planning details because of the fear of discussing and facing death, right? And so I think it's really important in everything that each of you have said. One term I keep hearing coming up consistently is care team. So my next question would be, what are some simple tips that you might offer to people who would consider themselves actual healthcare providers, the medical professionals, and family members, practical tips on how we begin to create a care team for loved ones that may need the care plan, or creating a care team to even get to the place where care planning can happen?
Well, I'll say the very first thing you want to do as a caregiver, I'll speak to the family caregiver. Um, you want to understand the condition that you're dealing with, right? If you're dealing with someone who is living with a form of dementia, you need to know what type of dementia it is so that way you can connect to that association. If you're caring for someone with congestive heart failure, then you want to ensure that the cardiologist is on the team and whatever resources the cardiologist has. You want to make sure you have the medical model involved. You want to make sure you have the social model involved. You want to make sure you have the community model involved, and also faith-based, because we know we as a people, we pray on everything, and that we should, but we know we have to have works behind it. And so better understanding the medical condition in which your loved one is dealing with will help start that process, will help connect you to the medical team. And then you don't want to leave yourself out of it. We always refer to the caregiver as the invisible patient. What do you need as a caregiver, as a person, as a woman, as a man, as a mother, right? What do you need? Because if you're not healthy, then you cannot provide support in a healthy way to the person you love. And what we know now is that approximately 35% of family caregivers actually pass away before the person with the chronic illness. And that's due to not putting themselves first and not taking care of themselves and recognizing their own medical emergencies. What I would say to the medical profession, and Dr. Bonds Johnson can probably speak to that a bit more. Uh, you know, they don't always let us in as allied health professionals. And I know they don't want the attorney coming in the office. You know what I mean? They don't always let us in. But what I think it's happening now, there is a paradigm shift, because what the pandemic has shined a spotlight on is that family caregivers and the community, we're the backbones to the long-term care system and the health system in general. And so we have to ensure that the healthcare providers have support as well. They have to have information. I mean, I know I'll talk out of both sides of my face, and I'm guilty of that. I say, if you lay hands on a senior, you're supposed to be trained in geriatric care. But I know that field is very, very slim. But at the same time, they can only make referrals and provide information on what they know. They think everybody's supposed to go to the nursing home if they have a chronic illness. But that's just what they know. And so we, as allied health professionals and community advocates, law partners, we have a responsibility to ensure that the first line of defense, which will be the doctor, has the resources they need in order to help families build a team.
Thank you for that. Dr. Bonds Johnson, what would you recommend if the patient is resistant to discussing their diagnosis? How should a caregiver then proceed? And Dr. Macy Smith just touched on that.
Definitely touched on it. I mean, at the end of the day, we're human, right? No one wants to die. No one wants to have a chronic illness. And so I tell people all the time, especially when they recently have a diagnosis of dementia, it is a terminal illness. We have no cure for it. That is depressive, that is anxiety producing. It is a tough situation. So I meet people where they are, right? So if you don't, I had one man, I'll never forget. I said, you have a diagnosis of dementia. And he said, I just don't subscribe to that. Okay, that's fine. Guess what? We'll talk about your memory, we'll talk about sleep, we'll talk about appetite, but we will not discuss using the term dementia in this visit. I will document accordingly in the note. And so I think sometimes people get so hung up with trying to say, well, you have this diagnosis, you have this problem, that you don't treat the symptoms associated with the diagnosis and the problems. Meet people where they are. At the end of the day, I came out of, mental health background. I dealt with a lot of people with bipolar, but they didn't want to subscribe to that. That's fine. As long as I'm treating the highs and the lows of these symptoms appropriately, then we get the outcomes we want. But do you have a provider that will meet you where you are? So I am a huge, we put a lot of onus, especially on underrepresented African-American families. Like, you just be more resilient, just do more, just be better, just blah, 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 blah. The list goes on and on. But there is a huge responsibility and onus on primary care providers. They are the gatekeepers to so many different things. Another thing COVID taught us is if you are not getting good care, if people aren't going to the hospital, hospitals shut down, there isn't the room for that. And so you are the consumer. If you are seeking health care and don't feel like your needs are being met, then you may need a different provider. So one of the questions you asked was, how do you find practical members of the team? Well, is the provider listening to you? Do you feel heard? Do you feel like your needs are being met when you see them? Because if so, that's somebody you want on the team. And so I think sometimes the approach that we have as clinicians can deter people from wanting to be seen, on top of the fear of a diagnosis like a dementia or something else. And so I think it's not only on the family to do their part, but also on the healthcare providers, the healthcare teams, to make sure that we are meeting people where they are and that we are treating them with dignity and respect and giving them a sense of agency while we are trying to walk out this journey with them.
I love the last piece that you said about also giving them a sense of agency while you're helping them. When I think about the matriarch of our family who passed 2 years ago, and I'm sure everybody on here has probably had their own big mama or auntie or whomever, she liked to be informed and included, especially she had her faculties for a long time after several strokes and defied some of what they thought initial outcomes may have been, but keeping her informed each step of the way and doing it as a team was something that I know she felt respected and it made a difference. So I thank you for emphasizing that. We have a question from someone in the audience. The question is, how do you best serve as a caregiver if your day-to-day life is already so overwhelming?
My initial response is that you should not be doing it by yourself.
Yeah,
If your
I
day-
agree.
Go ahead. Yeah. I feel like
No,
I've been
I
talking-
agree with that.
Yeah.
Oh, I'm sorry.
No, I said I
Um,
feel like I've been talking a lot. Go ahead, please.
Oh, no. I agree with that. So I'll give you some tangible resources there, right? You want to take advantage of and invest in in-home care services. It's a million out there, but you can go to your state's Department on Aging. Every state has a Department on Aging. Every county also has an area agency on aging. We call them the AAAs. You can reach out to them. They have vouchers for individuals who are caring for someone with cognitive impairment. They also connect you to senior programs and day centers. Adult day centers are underutilized, but they are an excellent form of respite. Many of them accept Medicaid, they accept Medicare, and they also accept private pay. If you are in the workforce, you want to tap into your EAP. Your job may have an EAP, they may not, but you want to ask about the employee assistance programs. They also offer connections with resources, community resources for caregivers. So those are a couple of pieces of nuggets you can take with you in terms of follow up, so that way you can actually get some tangible support in there with you if you don't have the opportunity or the ability to tap into family members to help you care, or they just don't want to do it. Look at your church community. Many churches now are involved with community outreach. They have grants to offer supports to seniors, also to adults with disabilities. So if you're not connected to a faith-based organization, reach out to one that's close to you in your community. Also, community centers. So community centers, almost all of them have a senior care arm where they offer senior care, they offer senior engagement. A lot of that is free of charge, but you just have to reach out and see what's available. And then you want to connect to the newsletter. You want to make sure that you are on the newsletter mail out, so that way you can see what's going on and what's happening, so that way you can connect with that.
Dr. Smith, we have another question for you specifically. How do you determine when to consider placing your loved one in a facility or daycare program versus in-home care?
So so two different things. So an adult day center, so that's where the person will go during the day, like 8 to 5, 9 to 6. Sometimes I can work it out to where they get there at 6 and can stay to 6 to 6, depending on the needs of that person. And so if you're working a full-time job and you can't be there to provide care, and that person may be dealing with isolation or depression, and you know that they need to be engaged with other people. We all do, because that stimulates our brain. Even if they have dementia, they still need to be engaged, because idle minds lead to dangerous behavior. Then you may look at adult day services, right? When it comes to in-home care, so if your loved one does not want to go out of the house, I mean, it's a fight. They not trying to leave. You already know that you're not going to be able to even get them to go to the mailbox. Then you know that you're going to need some help in the home, because you can't provide 24 hours a day care. And so that's when you will look for in-home placement. When you start to look for out-of-home placement, everybody is different. To Dr. Johnson's point, every family is different. Every situation is different. If you have, I always start with the least restrictive supports first. If you're taking in-home care support and you're still having stressors, meaning that person is not coming in, you've tried different agencies and you're still having to get off work, you're still stressing out, your blood pressure is through the roof, now you might have to look at out-of-home placement. But I will warn you, the price tag when it comes to assisted living, because when we talk about someone with dementia, they tend to go in assisted living because that's where the dementia community is. But if they have to go into assisted living, you're talking about on the low end, $5,000 a month, on the high end, $10,000 a month. And so you have to look at financially. So if you can afford it financially, you may look into that. If you can't afford out-of-home placement, then you may bring in-home care. You may have to staff it 24 hours a day. When you're there, you're there. When you're not there, then you might have to bring in support. And so, I think it's beneficial for the audience to know that there are geriatric care managers out there like me who can help them identify a plan of care and follow them along the way as the disease progresses, as life happens, as things occur, to help them. They ultimately make the decision, but to actually bring out factors, environmental factors that they may not see, that will help them make the decision. And so there is no right or wrong answer, but if you find yourself stressed, if you find yourself in a health emergency and your loved one is in a situation that is dangerous or harmful, then you have to look for the support services that are available either in home or out of home.
And I just want to add from personal experience, because my family, we had to create a team, and we several relatives worked rotations. And then outside of those rotations, there were in-home care providers that came. And so we were able to do that for quite some time. But I just want to encourage anyone who may be going through this or may in the future, that asking for help is a good thing. I think it's very important not to feel, especially again in our culture, and especially with a lot of African American women, that trope of the strong Black woman can be very unhealthy for us, right? So I just want to encourage folks from my own personal experience and with what our experts on the panelists have said here, to ask for help, to reach out for help and take it and use it. So our next question, how do we start the discussion of more sensitive topics such as brain or organ donation, hospice care, or burial versus cremation? Anybody can start off on this. How do we start that discussion?
I think that if we take out the idea of death, as in every single living thing on this planet is going to die. It just is. So if we take out that factor and make it more about empowerment, as in how cool is it that you get a chance to dictate what you want done with your body? As in, it's yours. Why shouldn't you have the right to say what you want done with it? Then it's less about it's going to happen or when it happens or whatever. It's okay, if it happens, this is what I want done. I watch so many people breathe sighs of relief when they've signed those documents because they know that they've put into place what they want done. And they have chosen the people that they trust to make their decisions, not, I should say, the owner's decisions, not the caregiver's decision. It's huge. So I love making it about, we're not talking about death. What can you do today to protect yourself, to protect your family? Which one of us wouldn't want to do that? You know, so it's like, stop thinking about the inevitable. Let's talk about today.
Thank you for that. That gave me chills. And even the tone change in your voice, thinking about
I believe
death
it
is
so much.
inevitable, but approaching the planning and the caretaking from a place of empowerment, right? And I think that,
And if I may,
yeah, sure. Go
I
ahead.
tell people it's a gift.
Yes.
You are giving your family a gift because you are laying out exactly what you want, how you want it. There's no need to argue. There's no need to guess. There's no need to question. It is a gift that you're handing them.
Not only that, but it releases the guilt. I've always noticed that when families fight after a loved one's passed away, it's for two reasons. One is they're already grieving. Grief is going to make you do things that you wouldn't normally do. Second, if you don't know what that person wanted and you didn't have that discussion with your family, there's a sense of betrayal. So when you mix grief with betrayal, the only person you're going to have to take that out on is the person standing in front of you. And it's not that person's fault any more than it is yours. So if you can take the feelings of guilt, the feelings of betrayal out of it by actually discussing with your family what you want, that just adds to the gift that Dr. Bonds Johnson was talking about. Like, seriously.
I love that. I think we have questions.
Well, somebody raised their hand and
Okay.
while we do that, if you want to go to the next question,
Okay.
we'll get them.
I think this is such a fruitful conversation. Thank you. Next question. This is for Attorney Wisenot. What are some of the legal necessities for care planning, such as trust, living wills, and long-term care insurance?
Sure. A lot of people believe that if they only have a will, that they're good to go. That's something I've heard a lot, and it is the furthest thing from the truth than you can have. A will is a dictate to a court, period. It does not give anything. It does not change anything. It literally tells whatever probate court, of whatever county you're in, what you want done with your things. But it doesn't give it to them. You still have to go through the probate process. So that's where having the other documents in place, like a trust, beneficiary forms, things that I talk to my clients about all the time. That's what's going to keep you out of that court, keep you out of having to spend so much more money with the courthouse, whether it be fees, legal fees, because how many of us know what to do in that court? You're going to end up having to hire someone like me. I would love to see that money stay in the pocket of those who the person wanted to have it than in mine. I want to help you from the beginning and be proactive rather than reactive. So things like your power of attorney, both healthcare and financial. Things like your HIPAA release. That sounds really simple, but so many of us have never signed one. Then unless you've had surgery or unless you've had to go to the hospital, you may not have one. So then you end up in a situation where you're in an emergency and there's no one that can receive your medical records. That right there is the first step to getting where you need to go. So I make sure you've got your HIPAA, that you've got transfer on debt designations for all things that can have it. There may not be things you didn't even know needed it. And so that's why I love being able to educate. And even if you don't hire me, I want to educate. I want to talk to you about what your options are. So having all of those documents in place, not just one, is incredibly important because they all work together.
Rayanne, I did see your hand. We have a couple of more questions before I come to you, but I didn't want you to think that I didn't see your raised hand. This is also for Attorney Whisenant. What are the differences between a traditional estate planning attorney and an elder law attorney?
Yes. So I know that we're talking right now about caregiving, and a lot of that comes down to caregiving for our elders. I'm actually a traditional estate planning attorney. I call myself a legacy attorney. I work with everybody. It's not that I'm specialized in one way or the other, but I focus more on the proactive. So I work more with younger families. However, those who need to go into a nursing home or to get that in-home care, that person may very well want an elder law attorney. And those are the ones that work a lot with people like, Dr. Bonds-Johnson and Dr. Smith, that focus on applying for Medicaid, focus on, asset protection when it comes to how you can put things away and still qualify, to have, your stay in the nursing home covered. They talk a lot about long-term care insurance. And though I talk about it as well, like they can attempt to help you get it. Long-term care insurance being, it would cover a certain period of time without having, to work with Medicaid. So that's why I say that you want to know the difference, because in whatever period of your life, you may need an elder care attorney instead of coming to someone like me. Or you may not be ready for an elder care attorney, and then you may want to come and talk to a traditional attorney. You need to figure out in what stage of your life you are so that you can be talking to the correct person the first time, especially with the fact that people charge, consultation fees. You may get further in and then realize that you needed something that person doesn't do. So you really have to do your due diligence to figure out, what you actually need. And so I wanted to make sure that we talked about the fact that there are attorneys that specifically deal with those of us in our golden years. And so you want to make sure that you have someone that works in that area in case you need that.
Can I say you were spot on. You did that perfectly.
Oh, thank you.
I'll say a lot of times I have certified elder attorneys on my team, and they come in to do just what you just said. Because what happens is people don't realize that Medicare does not cover long-term care, which means assisted living, in-home care, not home health. That's something totally different, but in-home care. They don't figure it out until they need it. And so now we're trying to scramble and help them qualify for Medicaid. So basically you got to become poor in order to afford long-term care, because you make $2 too much to qualify for Medicaid, but you don't have enough liquidity to pay $35 an hour for an in-home care provider. And so we bring in an elder attorney to help you spend down, preserve assets, basically qualify for Medicaid to be able to pay for these services. But if people know that early on in our prime, that Medicare is not going to cover this, then we do go and see Attorney Wisenot to be able to plan for longer term, be able to put finances away in annuity so that way you can actually pay for long-term care if and when you may need it. The data shows us that as you age, you're going to increase your risk of developing chronic illnesses in America. You know, over age of 65, you got at least one chronic illness. And so the chances that you will be a part of the, oh my God, former president, Rosalind Carter. First president's wife, Rosalind Carter. You're going to be a part of one of the communities. Either you have been a caregiver, either you are a caregiver, either you will need a caregiver, or you will be. So you're going to be a part of one of those groups. And so you have to start planning now. I also wanted to say too, you had mentioned when we talk about advanced care directives and the power of attorney. Sometimes, you know, our older adult population, they don't want to get the power of attorney in place because they feel like that means they're no longer able to make their own decisions. Or either on the flip side of that, family members who get the power of attorney, they swear up and down that they got all the control and can make all the decisions. A power of attorney is only effective when the person is unable to make decisions on their behalf, and it could be temporary. So, but you still want to have that in place in the event of you cannot make your decisions. And in some states, in the state of South Carolina, you can actually, you don't have to go to an attorney to get the form completed. You can actually go to, we send people to our bar association. You can print it out. In South Carolina, you don't even have to have it notarized. You just have to have the proper signatures on it, but you don't even have to have it notarized. In other states, you do. But I always recommend that you get an attorney and get it legalized, but you don't have to. As long as you have a legal document in place that's recognized by that state, you want to be sure that you have it. But that does not mean that you're giving your rights away and you're going to be, you know, held against your will or anything like that. It's just preparation.
Oh, please, can I speak to that? Yes.
Yeah.
Yes, thank you.
We have about 9 minutes or so left until we wrap up, so you know.
I promise I'll be very quick about this. Yes. If you have your own faculties, you have final say, period. I don't care if you've signed that document or not. It is not taking away your ability. It is giving the ability to someone you trust to do for you what you would have wanted done. So please do not think that it takes away anything. But the other piece I was going to say is, yes, you can print documents offline or you can go to the Bar Association, and none of those documents are wrong. What I worry about for people who do that is if you don't understand what you're signing, that's going to be a problem because it may be missing something. It may have something in it that you don't want in it. It could be anything. And so if you don't have it reviewed by an attorney, I realize that sounds like it's just more money coming out of your pocket. But let me promise you this. I have seen it where if there's something in it that you didn't want your caregiver to be able to do, but you've already signed it and now you are declared incompetent or no longer having your mental faculties, there is nothing you can do about that. So I say, please either talk to an attorney up front or have someone read it to make sure you understand what you just signed.
Oh, we have a question in the chat and another question to get to here. Let's see. Let's go to the chat really quickly. Why does the POA dissolve immediately upon death?
Because it only deals with while you are living. Powers of attorney, your living will, your HIPAA, those things end at death. What you have left are your will, your trust, and any transfer on death designations. So it is only valid while the person is still living.
Another question for you, Attorney Wisenot. What is guardianship and how can you incorporate it into your care plan?
Sure. Guardianship is where you are declared what I just said, like legally incompetent. Most people consider incompetency like something being stupid or not, or, you know, no, that has nothing to do with it. It is literally the fact that you no longer have the ability to make decisions and to do for yourself. because of your mental, say for any mental incapacity. A guardianship is where you are, say someone is going to apply to your probate court in whatever county you're in to say that you need someone to take care of you, that you need someone that is going to step in and take care of your person as well as your estate, which would be your funds. You get that person could be one and the same, or it could be two separate people, but there's always a guardian of a person, guardian of an estate. That is something that is a court order, which means that there's well, at least in Ohio, there's an investigation that is done. It is not just, made by the judge. Like there is an investigation done to figure out whether or not that person would be a valid, choice. What's different about it is once guardianship is put in place, it's almost always permanent. So you really have to make a decision as to whether or not you're, you know what I mean? That's what's really needed. And that's what's also really good about a power of attorney is that if it's written correctly and includes the right situations, you may not even need the guardianship, which would be more cumbersome as well as more expensive because it has yearly fees that the guardian has to pay. So I'm not discouraging, but just wanted to let you know that that's what it is.
We have 5 minutes left, and there are a few short questions in the chat. Perry Ann Fatika, who makes the decision on whether a person is competent or not? Anybody on the panel for that one?
I can speak to that really quickly and attorney-wise.
We can't hear you. You're away from your mic, I think.
Oh, I'm sorry. I had to plug in. Attorney-wise, and I definitely want you to jump in here. So I'll tell you, those are excellent questions, and I think we all see what's going on in the media with Wendy Williams. So in my experience, what happens here in South Carolina, typically someone somewhere petitions the probate court to say, hey, I think this person is being taken advantage of, whether or not it's financial, physical, or what have you, or if it's neglect. So what should happen is when they petition the court, the judge will assign that alleged, at the point it'll be an alleged incapacitated individual because an investigation has to take place. The person is assigned an attorney. The person is assigned a temporary guardian. The person is also assigned a guardian ad litem, which that person pays for out of their pocket, which, I got some thoughts on that too. Then there's also the attorney on the other side, right? Typically, the guardian ad litem is the person that goes in and does the assessment. They go in, and so as a guardian ad litem, I go in, I interview everybody. I interview family members. I interview the alleged incapacitated individual. I interview the alleged perpetrator, everybody. And so there's also a medical evaluation that's done on the person as well. And they are evaluating their mental health. I get that report, but I'll tell you, I look at that report as an afterthought, and I'll tell you why. Because if that doctor that's doing that assessment does not know that person's history, then they may not do well on that cognitive assessment because they're already going through stressful situations. They may not know what's going on. And so they don't know their history. And so that almost all the time, that report says that this person is incompetent.
Dr. Smith, I gotta hop in. I'm sorry.
Oh, you gotta cut me off? Okay. Well, the short answer is the judge makes a determination based on the reports that are given in the court.
Yes, this was such a great conversation. I wish we could continue, but we have to wrap up. Final thoughts, closing remarks, maybe if you have each like a 30-second gem that you can share before we close off. Attorney Whisenant, you got a maybe 30 seconds. Yeah.
Don't think of this as being something you should be scared of. Really lean into the fact that you get a chance to decide for yourself while you still have your faculties. So find somebody that you know, like, and trust that can help guide you, through this process.
Thank you. Dr. Kalisha Bonds Johnson, do you have maybe a short 30-second gem? Close us out.
Sorry, I was trying to answer this question online. Family matters, family dynamics matter. Chronic illness exacerbates all of that. And so just remember that you can do this, but you cannot do this alone.
Thank you. Dr. Macy Smith,
Real
like
quick.
30 seconds. Yep.
Just feel all your feels. I mean, you grieving, there's a process, feel all your feels. Don't be afraid to ask for help. There's power in that.
Thank you. I want to thank all of you for joining this evening. My short gem would be proactive. Do these things early and do it as a team, because if you do, then if that crisis comes, you can be fully attentive to giving care and enjoy the time that you have left with your loved one and be as least stressed as possible. So this wraps up our webinar for tonight. Thank you to our esteemed panelists to joining us this evening. Please make sure that you join us next week to continue our conversation on caregiving as we discuss caring for the caregiver, the importance of self-care. Following tonight's webinar, you will receive an email which will include the link to a resource packet for the series, the recording to this session, and a feedback survey. We encourage you to fill out the feedback survey following each webinar. Your feedback helps create the topics in future presentations such as these. Thank you, and we will see you next week. Have a great evening.